Unconsciousness is a common clinical problem and may be associated with diseases of several organs in the body. The cause of unconsciousness is often not immediately evident, and a systematic approach to its diagnosis and management is therefore important. Obtaining a thorough history from accompanying relatives, friends, and the places is often essential. So the main causes are infections like meningitis, cerebral malaria, and also hypoglycemia, as diabetes related or alcohol induced, diabetic ketoacidosis, severe hypertension with encephalopathy, cerebrovascular accident or stroke, drug ingestion or overdose, for example, alcohol, salicylates, barbiturates, cocaine, electrolyte imbalance, epilepsy, status epilepticus, head injury, major organ failure, for example, hepatic failure, renal failure, myocardial infarction, hypoxia from severe anemia, poisoning, for example, kerosene, pesticides, and herbicides. So the symptoms depend on the underlying cause, and the signs also depend on the underlying cause. The investigations, you test depending on the cause. So the test depends on the suspected cause. Mainly FBC, BF for malaria parasites, glucose, blood glucose, urea, and electrolytes, liver function tests, blood culture and sensitivity, urine culture and sensitivity, ECG, toxicology, drug screen, alcohol levels, lumbar puncture, head CT scan. So the main treatment objectives are to support life until consciousness is regained, and to prevent complications, for example, aspiration, hypoxia, and also to determine the underlying cause and manage it appropriately. Non-pharmacological treatments ensure the airway is patent and clear of secretions, and examine and stabilize the cervical spine if any history or sign of injury. Catheterize and monitor the urine output if necessary. Also place the patient in a position that would prevent aspiration in case of vomiting, or pass an NG tube if no contraindications exist. Pharmacological treatments. So if the patient's complaints, there's history of diabetes, use of oral antidiabetic or ingestion of alcohol, then the diagnosis will be hypoglycemia, and with the action you treat appropriately. With a history of injection of medication, tablets or liquid, there may be smell of alcohol or other substance on breath. If there's a complaint, then the likely diagnosis is drug overdose, for example, alcohol, and the action is support respiration, and give IV dextrose 10%, 50 to 100 milliliters to prevent hypoglycemia. And in chronic alcoholics, you precede IV dextrose by IV or IM, timing 100 milligrams IV, and then 50 to 100 milligrams IM until the patient regains consciousness. And also for paracetamol, that's drug overdose, you start N-acetyl cysteine as indicated, and you refer IV continuous infusion. Body weight more than 20 kilograms, give 100 milliliters of dextrose, 5%, always given over 15 minutes, followed by 50 milligrams per kilogram in 250 milliliters of dextrose, 5% over 4 hours, and then 100 milligrams per kilogram in 500 milliliters of dextrose, 5% over 16 hours. In children less than 20 kilograms weight, you give 150 milligrams per kilogram in 3 milliliters per kilogram of dextrose. 5% is given over 15 minutes, followed by 50 milligrams per kilogram in 7 milliliters per kilogram of dextrose. 5% is given over 4 hours, and then 100 milligrams per kilogram in 14 milliliters of dextrose, 5% over 16 hours. And if the complaint, there is a presence of or absence of history of diabetes, as polyuria, polydipsia, hyperventilation, gradual onset of illness, evidence of infection, and urine sugar and ketone positive, blood glucose more than 80 millimole per liter. You give diabetic ketoacidosis medications appropriately. So the likely diagnosis is ketoacidosis. And for high grade fever, seizures, headache, neck stiffness, altered consciousness, we think of meningitis and cerebral malaria, also epilepsy. So for meningitis as a likely diagnosis, you treat with appropriate antibiotics and anti-malarial. That's for the cerebral malaria, until either diagnosis is confirmed. And also for the history of previous seizures with sudden onset of convulsions with or without incontinence, think of epilepsy. You give diazepam IV slowly over 2 to 3 minutes, and you abort seizures and continue to start with anti-epileptic drug treatment. The patient with sudden onset of paralysis of one side of the body, that's stroke, you check blood pressure and blood glucose, and you continue with the appropriate action. With patient with hypertension, headaches, and seizures, we think of hypertensive encephalopathy. The action, you check blood pressure, and if it is more than 180, 110 millimeters mercury, you give oral or parenteral antihypertensive to reduce BP gradually. For sudden onset associated with cardiac arrhythmia or emotional crisis, think of syncope. And the action, unconsciousness is usually brief. Prompt awakening occurs, so you monitor vital signs, ECG, and reassure. Also, history of injury or alcoholism, signs of trauma, think of head injury. As a likely diagnosis, you treat laceration, stabilize cervical spine, X-ray, skull for fractures, and head CT scan. For history of heavy alcohol ingestion over many years, a history of jaundice and gradual onset of changes in sensorium, the likely diagnosis is hepatic failure, and action, you manage as hepatic encephalopathy. So for diaphoresis, cold, clammy skin, and weak pulses, the likely diagnoses are shock, hypovolemic, could be hemorrhagic, cardiogenic, or even septic. So you treat appropriately. So referral criteria, so refer to a specialist for further definitive management if not responding to standard measures of resuscitation.